Thank you for kind introduction. My name is Hanjun Kim from Seoul Regional University Hospital. First of all, I would like to thank the organizing committee for giving me this opportunity. The title given to me is Clinical Manifestations and Red Flag Signs of Atypical Parkinsonism. I have nothing to disclose, and the learning objectives of this talk is to differentiate atypical Parkinsonism based on clinical features. Atypical Parkinsonism refers to a group of disorders, including MSA, PSP, CBS, and DLB. And in this talk and throughout this session, these are three disorders, MSA, PSP, and CBS will be discussed. I will start with MSA. MSA is an adult onset fatal neurodegenerative disease, which is characterized by various combinations of Parkinsonism, ataxia, and autonomic failure, as shown in this figure. It is a very rare disease with the prevalence of 2 to 5 per 100,000, and onset age is around 55 to 60 years, and median time from initial symptom to aid recurring walking is 3 years, confinement to wheelchair is 5 years, bedridden 8 years, and death 9 years. As you see in this figure, median survival of MSA ranges from 6 to 10 years. Current diagnostic criteria, which was published in 2008, provides 2 levels of clinical diagnosis. If a patient has severe autonomic dysfunctions like this, and polyrhabdopa responsive Parkinsonism and or cerebral dysfunction, a diagnosis of probable MSA can be made. If a patient's autonomic dysfunction is not that severe, then in this case, one additional feature is needed to make a diagnosis of a possible MSA. MSA-P or MSA-C is determined according to the predominant motor symptoms at the time of evaluation. This diagnostic criteria is now under revision, and we will soon have new diagnostic criteria or maybe it already have been published when this talk is released. Parkinsonism in MSA refers to bradykinesia with rigidity, tremor, or postural instability, which is poorly responsive to levodopa treatment. Rest tremor is less common than in Parkinson's disease, but 33 to 50% of MSA patients have rest tremor, and pill-rolling rest tremor, characteristic of Parkinson's disease, also occurs in some MSA patients. Generally, it is thought that Parkinsonism in MSA is symmetric, but this US natural history study showed that 43% of MSA-P patients have unilateral onset Parkinsonism, and this asymmetry persists in 40% of patients. Even in MSA-C, Parkinsonism is asymmetric in some patients, and this asymmetry in Parkinsonism correlates with imaging changes in many patients. Levodopa responsiveness is reported in MSA. In these 2 large prospective natural history studies, 43% to 57% of MSA-P patients reported some degree of levodopa responsiveness, especially in the early 3 or 4 years. Cerebral dysfunctions include gait ataxia, dysarthria, limb ataxia, and oculomotor dysfunction. This patient shows typical characteristic scanning speech. Oculomotor dysfunctions in MSA-P is characterized by saccadic hypometria, whereas MSA-C is characterized by saccadic hypermetria, gaze-evoked nystagmus, downbeat nystagmus, and rebound nystagmus. Interestingly, vertical gaze palsy, which is characteristic of PSP, also occurs in MSA. This study showed that 27% of MSA patients had vertical gaze palsy, but vertical gaze palsy was always mild, with up gaze always more affected than down gaze. And in autopsy-proven MSA patients, 14 to 21% of patients had vertical gaze palsy. However, vertical gaze palsy in MSA is usually late feature, but this may lead misdiagnosis of MSA as PSP. Among these oculomotor dysfunctions, perverted head shaking nystagmus and positional downbeat nystagmus indicate cerebellar involvement. These features are occasionally observed in MSA-P patients without other cerebellar features, as shown here. So if your patients with asymmetric Parkinsonism have these features, especially perverted head shaking nystagmus, you should think about MSA-P. Autonomic dysfunction is essential for MSA, and patients with MSA experience this wide range of autonomic dysfunctions. Among these, urinary dysfunction and orthostatic hypotension is included in current diagnostic criteria. Autonomic dysfunction is the first symptom in 23 to 43% of patients, and it is central dysautonomia, but recent studies suggest additional postganglionic autonomic dysfunction. Urinary dysfunction usually precedes orthostatic hypotension. This recent study showed that 18% of patients present with bladder dysfunction as the sole initial manifestation, and mean interval from the onset of urinary to onset of motor symptom was 2.8 years. Patients usually start with frequency, nocturia, urgency, and then urge incontinence. And with disease progression, patients develop voiding difficulty, retention, and finally use of catheterization. Voiding difficulty and retention in MSA is characterized by post-voidal residual volume greater than 100 milliliter, and this is specific for MSA compared with other Parkinsonian disorders. And this study showed that post-voidal residual volume exceeds 100 milliliter from the second year of disease. Neurogenic orthostatic hypotension refers to drop in systolic BP greater than 30 or drop in diastolic BP greater than 15 within 3 minutes of standing. Symptoms include dizziness, nausea, headache, potent pain, and syncope. In lab testing, neurogenic orthostatic hypotension is characterized by no overshoot in BP after the Valsalva strain, as shown here, and prolonged Valsalva pressure recovery time, as shown here, and blunted reflex tachycardia, as shown here. In addition, neurogenic orthostatic hypotension in MSA is characterized by supine plasma norepinephrine level greater than 100 picogram per milliliter, which is much lower in Lewy body disorders. In contrast, PSP is not associated with neurogenic orthostatic hypotension. Widespread progressive anhidrosis occurs in MSA, as shown in this figure. This is change over 3 years, and this kind of change does not occur in PD patients. Pre- and post-ganglionic abnormalities coexist, and increasing frequency of post-ganglionic pseudomotor dysfunction over time was reported in a recent study. Sexual dysfunction is common, as shown here, and male erectile dysfunction is almost invariable. In addition, patients have other features, including features known as red flag signs. Craniofacial dystonia with levodopa is a form of levodopa-induced dyskinesia. It occurs in the absence of limb dyskinesia and not accompanied by motor improvements. It usually develops at lower dose of levodopa compared with dyskinesia in Parkinson's disease. However, generalized and poriform dyskinesias, as in Parkinson's disease, also occurs in MSA. Pyramidal signs are common, as shown here. So this may lead to wrong diagnosis of motor neuron disease, but spasticity is not common in MSA. Pathophysiology includes loss of beta cells and corticospinal tract demyelination. Dysphagia is also common, and our recent study showed that 69% of patients with early MSA reported some degree of dysphagia. So patients should be screened for dysphagia at the time of diagnosis. Our study showed that latency from the onset of dysphagia to the onset of dietary modification was 2.3 years in MSA-P and 5 years in MSA-C. And dysphagia is associated with poor survival. This patient shows a jerky myoclonic postural kinetic tremor, which is also known as mini polymyoclonus or polymini myoclonus. This feature occurs in MSA patients, but it is not specific to MSA. Stridor is a very important symptom, and it is caused by laryngeal dysfunction leading to narrowing of the rima glottidis. It is under-recognized symptom, and the diagnosis can be improved by audio recording by patient or sleep partner, or imitation of stridor by the physician at clinic, like this. Inspiratory signs is also included as red flag signs in the current diagnostic criteria. Postural deformity in MSA includes antiquolis, camptochomia, and PISA syndrome, but these features can occur in other disorders, including Parkinson's disease. Cold and violaceous hands looks like this, and this region also shows the delayed capillary refill after blanching. Pathologic laughter or crying can lead to social isolation and may coexist with mood disorders. Dementia is included as exclusion criteria, but mild, moderate, and severe cognitive impairment in autopsy-confirmed MSA were 22, 2, and 0.5% respectively, and executive dysfunction is the most prominent symptom. Hallucination is very rare, but it has been reported in autopsy-confirmed MSA. However, these features are usually late features in MSA, and early multi-domain cognitive deficits and visual hallucination in patients with Parkinsonism and dysautonomia argue for DLB diagnosis rather than MSA-P diagnosis. RBD is very common, with a prevalence of 88%, which is much higher compared with Parkinson's disease. In 30% of patients, RBD precedes the onset of MSA onset, and this is associated with more rapid progression and increased mortality. Pain is usually experienced as deep aching pain that occurs throughout